Okay.
Okay. Okay. Good morning, everybody. I'm Dr. Undi, and I'll be presenting Pseudotumor Cerebri with normal pressure variant. Okay, I'll start with this outline, introduction and epidemiology, pathogenesis, the clinical features, diagnosis, management, and then prognosis and summary. Pseudotumor cerebri is a disorder defined by the clinical criteria that includes symptoms and signs isolated to those produced by increased intracranial pressure, such as headache, vision loss, papilledema. And then it also has elevated intracranial pressure with normal CSF composition, and there is no other cause of intracranial hypertension evidence or neuroimaging. It's also known as idiopathic intracranial hypertension because we don't have any structural cause. And a variant of it, known as the normal pressure pseudotumor cerebri, has the same features, except that it has a normal CSF opening pressure. An incidence is about 0.9 to 1 per 100,000. It's commoner in women than men, commoner in obese women, and commoner in women of childbearing age. It's probably due to the hormones involved at that time. And although it can present at any age, it's usually presents in the third decade of life. And men with pseudotumor cerebri are twice as likely as women to develop to lose their visual function as a result of papilledema, probably because of late diagnosis, as it is not that common in men and it might not be diagnosed on time. It can also occur in the pediatric population, and these patients are not obese. It has no racial or ethnic predilection. Pseudotumor cerebri does not have any known cause, and patients with higher BMI and recent weight gain have been shown to be at increased risk. So some of the risk factors, if we have a patient who is not overweight and presents with typical features of pseudotumor cerebri, such as the headache and a fundoscopic examination shows papilledema, the following have to be ruled out: exposure to or withdrawal from certain substances such as steroids, growth hormone, vitamin A. Vitamin A has been postulated to be seen in the CSF of patients with pseudotumor cerebri. However, they haven't a link showing how it causes it has not yet been established. Systemic disease such as anemia, chronic kidney disease, SLE, multiple sclerosis, and then disruption of cerebral venous flow, such as venous sinus thrombosis and also stenosis and dural fistula. And then certain endocrine and metabolic disorders such as PCOS, Addison's disease have to be ruled out. Also, increased venous red blood cell aggregation and relatively elevated fibrinogen concentrations have been demonstrated in patients with pseudotumor cerebri as compared to matched control subjects. And then the ratio of retinol binding protein, this is where the vitamin A comes in. It has also been shown to be elevated in the CSF of patients with pseudotumor cerebri as compared with non-IRH neurological control subjects and with normal control subjects. The most common clinical features were headache, transient visual obscuration such as gray vision, blurred vision, pulsatile tinnitus, photopsia such as flashes of light, back pain, retrobulbar pain, diplopia, and sustained visual loss. And the most common signs were papilledema, which can be graded in severity using the Friesen scale, which is important for prognosis, visual field loss, and adjacent nerve palsy. So this is the Friesen scale for grading papilledema. It's long, so I'll just show you pictures instead. So this is normal optic disc. You can see the blood vessels here. There's no, and then the optic disc cup is not swollen. But in grade 1, you can also see the C-shaped halo of the disc edema. Let me get this with a temporal gap here. By grade 2, the edema is circumferential, and then by grade 3, there's obscuration of a major blood vessel that is leaving the optic disc. By grade 4, there's the major vessel is obstructed from optic disc even without it leaving, and by grade 5, you can see partial obscuration of all the major blood vessels. And then the variant of pseudotumor cerebri has the same features except for the normal opening pressure. Normal opening pressure is between 10 to 25 centimeters of water. So a study that I noted, because I couldn't find much data on it, however, a study came to the following conclusions on normal pressure pseudotumor cerebri, that a single lumbar puncture is neither diagnostic nor exclusive in suspected cases. Open pressure measured during lumbar puncture is actually a snapshot of a highly dynamic process, and the results of the open pressure measurement must be correlated with the clinical history, clinical signs, and symptoms of the patient and results of follow-up studies. And although increased open pressure is a criteria for diagnosing pseudotumor cerebri, it should also be kept in mind that some patients up to this are most susceptible to lower intracranial pressure than others. And even when a patient's ICP is within the normal range, the possibility should always be considered in a patient that has the typical clinical features, such as the papilledema, headache, and tinnitus, and blind spot enlargement by visual field testing. So prompt diagnosis and treatment are essential to preserve vision. These patients are also treated with carbonic anhydrase inhibitors, such as acetazolamide, and clinical improvement has also been shown in these patients with so-called normal pressure pseudotumor cerebri. So the diagnosis is done according to the modified Gandhi criteria, which is symptoms and signs of raised intracranial pressure, such as the headache, tinnitus, papilledema, no other neurologic abnormalities or impaired level of consciousness, elevated intracranial pressure with normal CSF composition, and a neuroimaging study that shows no cause for intracranial hypertension, and then no other cause of intracranial hypertension apparent. Diagnosis is done with CT scan to rule out any structural abnormalities that might be causing the raised pressure. MRI with MRI venography, which is the gold standard because it helps to look at the cerebral veins and make sure there's no stenosis or thrombosis in the cerebral veins, which has been postulated to be a cause of pseudotumor cerebri. Then lumbar puncture is done for measurement of the open pressure and CSF analysis with cell counts, gram stain, and protein and glucose concentration. Ophthalmologic evaluation is required to document the severity of the optic nerve involvement, and is also done to measure the treatment, measure response to treatment. Then orbital ultrasound and fluorescent angiography can be done if after doing ophthalmologic evaluation, papilledema is not readily diagnosed. BP measurement is also important because patients with marginal hypertension with optic neuropathy may also present with headaches and papilledema, so it's important to measure their systemic BP. Also, blood tests such as CBC, this is to rule out anemia, because it has been shown that some patients with anemia, when the anemia has been corrected, pseudotumor cerebri has improved. C-reactive protein for inflammatory causes, and anti-cardiolipin antibodies and antiphospholipid antibodies for causes of thrombosis. So this is an MRI showing the first two pictures, A and B, show normal brain imaging. Then you can see a partially empty cellar, which is actually seen in 70% of patients with pseudotumor cerebri. The cause is not known. And then in D, you can see the tortuosity of the optic nerves. And in E and F, you can see that the right transverse sinus is a little bit enlarged. Sorry, the left transverse sinus is a little bit enlarged.
No, it's right. Oh, I see.
The management goals, that's right here. The management goals include alleviation of two major goals: alleviation of symptoms, usually headache, and the preservation of vision. And then any potential agents that might cause or worsen it may have to be discontinued. Tetracyclines have been shown to increase pressure. So if the patient is on a tetracycline derivative, it has to be discontinued. And then patients should be questioned also regarding symptoms of sleep apnea, because it has been shown to worsen pseudotumor cerebri symptoms, and diagnostic sleep study and treatment should be done where appropriate. Low sodium weight reduction program is recommended for all obese patients, and appears to alleviate the symptoms and signs in many patients. And medical treatment for pseudotumor cerebri starts with carbonic anhydrase inhibitors such as acetazolamide, which has been shown to reduce the CSF pressure and improve vision. Loop diuretics such as furosemide can also be used, and this has when patient does not have a complete response to acetazolamide. As I mentioned earlier, iron supplementation can be given to patients with IIH who have iron deficiency, because it has been shown to be efficacious in a case series. And then two main surgical procedures are optic nerve sheath fenestration and CSF shunting procedures. Surgical management is indicated when there is incomplete response, progressive visual loss, incomplete response to medical treatment, progressive visual loss, and intractable symptoms of headache. The optic nerve sheath fenestration surgery is done to improve vision, and it has been shown to improve vision loss in patients who already have papilledema. CSF shunting procedures such as ventriculoperitoneal shunt and lumboperitoneal shunting have also been done and been shown to reduce the headaches, to reduce CSF pressure and reduce the headaches. Cerebral venous sinus stenting is still kind of controversial, but people have been postulating it because some of the patients with pseudotumor cerebri have been shown to have stenosis of some of the cerebral veins, and so they postulated that if we can stent these veins, it might improve the pressure. Treatments that have a limited role are steroids and serial lumbar punctures. Steroids are not advocated because steroids cause weight gain, obviously, and withdrawal from steroids can cause intractable headache, which can worsen the symptoms of pseudotumor cerebri. Then however, steroids can be used as like an adjunct before surgery to help to reduce the pressure, but it's not a long-term treatment. Serial lumbar punctures have not really been shown to benefit patients because CSF reforms in about 6 hours, and also it has the risk of infections and CSF leak, which can also cause a continuous headache for these patients. But it can also be used just like the glucocorticoids as a temporizing measure before surgery if the patient does not respond to medical treatments like acetazolamide. So the prognosis, there's no large prospective series that describe the natural history of this, and a protracted course, usually lasting months to years, appears to be common, and most patients' symptoms worsen slowly. However, with treatment, there's usually gradual improvement and stabilization, but not recovery. And many patients have persistent papilledema, elevated ICP, and residual visual field deficits. The risk factors for a poor prognosis are the present grade 3 to 5 papilledema that I showed earlier, and significant visual loss at presentation, male gender, systemic hypertension, anemia, black race, younger age or onset in puberty, and more severe obesity or recent weight gain. Higher opening pressure on lumbar puncture too. The presence or absence of findings on MRI has not been shown to predict prognosis in any way. And a feature of good prognosis is the absence of papilledema on endoscopic examination. So in summary, the pathogenesis of pseudotumor cerebri is unknown, and it typically presents in an obese woman of childbearing age who presents with headache with papilledema on examination. And a neuroimaging study is usually needed to exclude other causes of elevated intracranial pressure, such as tumors, before a diagnosis of pseudotumor cerebri can be made. And then medical and surgical treatments are based on the patient's presentation. Thank you.
Wonderful presentation. I have a question. How do you
Yep.
diagnose? How do you diagnose pseudotumor cerebri with a normal visual field, with normal vision? Pardon me. Where there's no papilledema. You look in the eyes and it's normal. How do you jump to the diagnosis?
I didn't see that, but I saw if there's headache, the patient has other symptoms like tinnitus, and even if you do a visual examination and the visual field, there's no obvious papilledema, they give them a trial of acetazolamide, and if their symptoms improve, then they diagnose them with pseudotumor cerebri.
I think that was a fantastic presentation.
Thank you.
Let me stop the recording a second.